Hi, my name is Chris Meduri from the Piedmont Heart Institute in Atlanta, Georgia, and it's my pleasure to be here today with my good friends, Dr. Gorav Ailawadi, as well as Paul Sorajja. And here we're really having an interesting discussion on what's happening in the transcatheter space. And what we've seen lately is that there's a growing need, as we've seen in the aortic originally and now mitral, to really look at the tricuspid space. And so I want to talk with our colleagues here today about what they see is coming down the pipeline of the future and what the real needs are in this space. So Paul, what have you been seeing and learning lately in the tricuspid space?
Well, Chris, and thank you for having us here. I have to say that the tricuspid space is definitely, the future is very bright. There's a lot that we don't know about the tricuspid in terms of how to approach the disease, but I think there's a lot that needs to be done because a lot of what we do for tricuspid will help drive our other technologies, whether it's aortic or mitral.
Oh, that's really interesting. And Gorav, what do you think are the bigger challenges we're going to face as we try to enter into this new frontier?
Well, I think we can learn lessons from surgery. From surgery, we know that the tricuspid valve is honestly the easiest valve for us to fix. It's literally 9, 10, or 11 stitches, and you put a ring on, and that's about it. Unfortunately, it's a marker of bad things like right heart dysfunction, and ultimately a lot of these patients, with or without an operation, die of multi-system organ failure. So we also know from surgery that the mortality of any patient undergoing a tricuspid operation is upwards of 10%. So because of these, there's definitely a need to understand how can we fix this better, whether it's a less invasive or percutaneous or a combination of techniques. And also similar, I think, to surgical mitral valve repair for functional mitral regurgitation. Functional tricuspid regurgitation is similar in that we often see recurrences with purely putting a ring on it. I think we are just starting to become smarter. The limitations are a bit different, I think, in the tricuspid space. Certainly it's a lower pressure system, which helps, but it's also a much larger surface area of the valve, and makes it more challenging when we start thinking about ways to repair or replace the valve.
So when we think about the tricuspid valve, people often call it the forgotten valve. And you know, we've always had natural referral patterns for our aortic patients, as well as our mitral patients. But normally, as you said, the mortality risk is so high for surgery, people don't really even think about sending us TR patients, even though we know there's a lot out there. What kind of approaches do you think could try to shift the paradigm of thinking about these patients earlier instead of getting them at the very ends of the disease process?
Well, I think there's just a general lack of awareness, as you say, and TR, as we all know, is a terrible marker of an adverse prognosis. I mean, it typically doubles the mortality for any given procedure and any given disease. And so I think there's just a general lack of awareness. And I think that's largely because in the current practice, it's usually treated in conjunction with something rather than independently thought of on its own. Yeah. And so if you look at the current guidelines, there are very few statements on isolated tricuspid disease by itself. It's essentially all in conjunction with left-sided disease. But unless we address it and think of it independently, we'll never be able to address what needs to be done in terms of designing technologies that address the tricuspid valve by itself.
That's very interesting.
I think the other point is that if we wait till the patient becomes symptomatic, oftentimes it's too late. The RV is too blown out. They already have some element of renal dysfunction or liver dysfunction, and then they've already gotten down that slippery slope, and it can sometimes be hard to bring them back. And so I think, as Paul mentioned, in heightened awareness from the cardiology community to look for this disease. It's a bit similar as we think about mitral valve disease. We've certainly gotten smarter. We now know to refer patients with degenerative mitral regurgitation before they have symptoms because we've learned that that's a better outcome for them. And I suspect that as we get smarter about both aortic stenosis and tricuspid regurgitation, we'll see probably similar patterns.
Okay, that's great. Well, I want to thank you guys so much for spending time with us here, and we look forward to many more discussions about the tricuspid valve.
Right.
Thank you.
Thank you.